So let's say now we're moving on. You get the CTA. It's a type A or thoracic aortic dissection. What's your when you pull that CT scan, you see it. Like, what's your next steps in reevaluating the patient, and what are your thoughts on moving forward and how you need to care for this patient?
The other thing you have to really look at on the CTA that people don't pay attention to is whether there's a pericardial effusion.
Yeah.
When there's a dissection, think pericardial effusion. Is there one or not? And look at the CTA. You don't need the ultrasound because the CTA is pretty good at finding it. If there's no pericardial effusion and the blood pressure's high, the heart rate's high, despite a lot of pain medicines, then you're going to be a lot more liberal now about your pain medication regimen. You're going to need to think about reducing the blood pressure and the heart rate. In the history of treating aortic dissection, initially it was treated with bed rest, which just didn't work. It gave you a great natural history to the disease where like 60% of people with type A dissections will die in the first few days,
Yeah.
and then all of them will die after a year. Then they added some pharmacotherapies with beta blockade and also calcium channel blockade to reduce the blood pressure and the heart rate because they're trying to reduce shear stress. And that seemed to have dramatically reduced short-term mortality, but had no influence on long-term mortality for type A dissections. And so for that reason, if the person's not in shock or eminently going to be in shock, then you should definitely start some sort of rhythm and blood pressure control.
Okay. What are kind of your go-to agents for that in terms of, what do you like to order for those?
Yeah, that's a great question. The textbook answer is to give esmolol and then nicardipine, and esmolol first because you want to avoid the reflex tachycardia from nicardipine. The truth is that you almost never get reflex tachycardia with nicardipine. It also blocks the calcium channels in the heart too and can sometimes cause bradycardia on its own. The other thing is that esmolol is not that common in a community ER. Not infrequently we get calls and the person says, I know I'm supposed to give esmolol, but we don't have it. Well, there's nothing magical about esmolol. It's actually a metabolic byproduct of metoprolol. It's just shorter acting. And there's nothing wrong with giving metoprolol IV because you want it, in their system reliably, or labetalol IV, or diltiazem. Diltiazem would actually be a fantastic drug in aortic dissection because unlike the beta blockers, which take like half an hour to really slow down the heart rate, calcium channel blockers will instantly slow it. You start the drip, the heart rate will come right down. So the cocktail really would be like, which one is the bigger problem? And if they're both problems, you're tachycardic and you're hypertensive, I would go with labetalol, quite honestly, or metoprolol pushes. If you're still very tachycardic, but your blood pressure is starting to get more reasonable, I would probably put you on a diltiazem drip. Especially if you don't have a pericardial effusion. That's really important. And then if the blood pressure is more of a problem than heart rate, which is also pretty common, then I would put you on nicardipine, and that itself will it won't get you that much faster, but it'll do a really nice job of bringing your blood pressure down.
What goals are you shooting for in terms of your SVP and your heart rate for these patients?
The best answer is as low as tolerated. The textbook answer and the practical answer is heart rate less than 70 and blood pressure less than 120 systolic. The heart rate less than 70 is actually the hardest part because the thing that controls your heart rate mostly when it's less than 100 is actually your parasympathetic tone. Your sinus node wants to go at a heart rate of 100. So to get less than 100, you need some degree of parasympathetic tone and the absence of sympathetic tone to get it below 100. Even if you beta block, for example, a patient with a transplanted heart, so they don't have parasympathetic tone, their heart rate will never go below 90 because that's the native rate of your sinus node. So that's why diltiazem is sometimes the only way you could get their heart rate to that goal. But most of us start with beta blockers, mostly out of culture, but there's nothing wrong with using diltiazem in this case. And then the blood pressure, nicardipine to get it below 120. And if the plan is medical therapy, then we start transitioning towards oral regimen pretty quickly.
Okay, sounds good. In terms of that, like we were talking about thoracic aortic dissection, if it's a type B or, a lower down dissection, does any of that change in terms of your heart rate blood pressure goal or the regimen you're choosing, or is it the same?
It's the same. Okay. As low as reasonably tolerated. Sometimes we nudge these goals up a bit, depending on whether we think perfusion is being compromised. And that's hard to tell.
Yeah.
It's really hard to tell. So like, for example, if the person's always super hypertensive and their creatinine's starting to bump, we might nudge the systolic goal up just a smidge to 130 or something like that. The other thing that makes it really hard is that sometimes people get paralyzed from this. And if they get paralyzed, one of the treatments is actually to bring the blood pressure up. And this is highly debated what you should do when the dissection or aneurysm is not secured, whether it's safe to do that. Because if you secured it, it's absolutely safe, and we actually use pressors to bring the blood pressure up. But when it's unsecured, the risk-benefit ratio is really not clear. And it's something that you're probably just going to need to talk to your surgeons about. Most of the time, though, your surgeons will prefer to just leave the blood pressure low.
Low.
Yeah.
Okay. And then, you've made this diagnosis and you've treated this patient, are there any labs that you actually really care about after you got the CTA with the dissection? Is there any lab that would come back that would change any management at all for you?
Their degree of metabolic acidosis and lactic acidosis will tell you their degree of shock that you are not as easily able to assess because their sympathetic tone might be really high. Okay. And so some things that would definitely raise an eyebrow, and we've had this recently, would be if the lactate is extremely high or the metabolic acidosis is really bad. And that would speak to some sort of low flow state if the blood pressure is normal to high, right? Because perfusion is dependent on blood pressure and flow. Yeah. And if you got great pressure but you got terrible perfusion, there's something wrong with your flow. And that would make you search a little bit harder for organ hypoperfusion. And you should always be searching for that, to be honest with you. But now you're really looking at all the extremities. Do they all have great perfusion? You have to think about the gut, whether that has good perfusion, and you have ischemic gut because the dissection has extended its way down. Imaging will really help you with that. Yeah. Is it involving the SMA and the celiac? Is it not? The other thing you have to think about is kind of general total body shock, which is there pericardial effusion causing tamponade? Is there severe aortic regurgitation because this thing has cut through the aortic valve? Mm-hmm. Is there cardiogenic shock? Because a lot of the ways these people die too is that the dissection flap actually transects the RCA and sometimes the LAD. And then you have basically a massive MI on top of all this, and you have no cardiac output. Yeah. Okay. So it's really looking at end organ perfusion in the labs and making sure that they're perfusing well. Yeah. The LFTs make a big difference there, especially if the SMA is involved, or the celiac is involved. I'm sorry. We really trend the LFTs to see if that's getting worse or not. Okay. So I think we've talked about the patient, thoracic aortic dissection that's, hypertensive, and kind of hit on that. Let's think about some bad stuff that can happen, especially, in the ED, if you're in a community ED, and how you would address some of those things. Mm-hmm. I think you touched on, pericardial effusion multiple times, and that this is really bad. So let's say you get the CTA or you put on the ultrasound probe and you see this large pericardial effusion. First of all, maybe you could touch on what do you look at on the ultrasound when you're trying to diagnose tamponade, and if this is tamponade physiology versus just a pericardial effusion. Yeah. First of all, the pericardial effusion that happens during dissections are usually not big. Yeah. Because they happen so quickly the sac hasn't had a chance to expand. Yeah. And the question on the ultrasound is a really good one, because a lot of people are trying to get fancy looking at the respiratory variation in the tricuspid mitral valve, even the LVOT variation with breathing. And that gets kind of fancy, and there's reasons why there is huge variations. But I think the key to understanding the physiology of tamponade is that there's nothing wrong with the heart. It's what's happening around the heart and outside of the heart that defines tamponade. Poor cardiac output as a result of poor venous return. And when you phrase it that way, you start to understand why putting the ultrasound on the heart might be a misleading place to look if tamponade is defined by what's happening outside the heart. And so for me, it's way easier to diagnose tamponade, in my opinion, by looking outside the heart. And that's where, again, feeling the pulse is really helpful to you. If you're in doubt because the person's in shock, putting in an A-line and looking at how much the arterial pressure drops with respiration is another way to measure what's happening. And the best ultrasound you can do on someone with tamponade is actually an IVC ultrasound. Because really you want to know, is there decreased venous return.
Mm.
And so, in that case, the IVC will be big, right? Because there's impedance to venous return. And if you were savvy enough to Doppler the IVC, which I like to do, you will see almost the exact same thing you see on the arterial side, which is that when the patient breathes in, there's flow through the IVC, and when they don't breathe in, they stop negative pressure inspiration, there's no flow. And that's very telling, that venous return is now phasic to respiration, and that defines tamponade.
Oh, wow. So that's interesting. You actually don't really spend too much time looking at the effusion around the heart, and you look at these other measures.
Yeah.
So let's say you do that for our patient, and they're not hypertensive, they're maybe a little hypotensive, they have tamponade. We don't have to go fully into like pericardiocentesis, but obviously that's the next step, and you would probably be doing that rather quickly for these patients, I'm guessing.
Yeah, I mean, you would probably start by giving them a lot of volume.
Okay.
Because you can try and overcome the resistance to venous return by just increasing the venous pressure through very aggressive volume resuscitation. We actually just had a case of this last month, you and I, where the patient, turns out they had a dissection, but they almost died upon intubation, no surprise, and needed 5 to 6 liters of volume just to keep this blood pressure in the 70s.
Yeah.
But that kept the blood pressure in the 70s, right? So the treatment of choice is go with volume. In this case, don't slow them down no matter what. And obviously, no afterload reduction if their blood pressure is already low. The decision on draining it completely depends on how quickly a surgeon can get to it. Because if it's going to be a delay, you're probably better off draining it. But the problem is that this is going to be a drainage ad infinitum, right? Because there's going to be blood that keeps going in, and the more you drain it, the more it'll bleed into that space.
Yeah.
So it's not a good permanent solution at all. It's a terrible permanent solution. And the worst case scenario, some surgeon will say, I'm not operating because you violated my field. This is a decision that I come to, even though I'm very trigger happy with procedures, I'm very reticent to do this. So fluid first, very aggressively. Tolerate hypotension, but obviously it has to be compatible with life. So MAP above 60, 65. Ignore the heart rate. And see how quickly a surgeon can truly drain it. Otherwise, you would really think about draining it, but with some reservation.
Okay. At what point are you done with your fluid resuscitation and you're like saying you're in a rural setting, surgeon can't get there, they have to transport this patient, they have a tamponade, they're hypotensive, like how many liters of fluids are you going to give them before you're saying like, let's just put it in a drain?
I don't think there's a clear answer to that. I think if they're in shock and they have fluid around the heart, I would definitely put in an A-line. And if they are responsive to the volume, then I would keep giving it. If they're not responsive to the volume, you're probably going to drain it. Some people might say just add a little bit of norepinephrine, and that's probably okay too. It's going to be an individual provider threshold.
Okay. So then let's kind of switch, like let's say there's a aortic dissection patient sitting in front of you and they're hypotensive, but they don't have tamponade.
Mm-hmm.
Maybe not as common a situation, but what are kind of your thoughts to managing them there? Is it still fluid first and then pressors, or kind of how are you going to approach that situation?
It kind of depends on what the problem is. So there's probably 3 scenarios that's going through my head if I see a hypotensive dissection patient, and luckily that CT scan with which you use to diagnose the dissection is incredibly helpful.
Yeah.
The first scenario would be whether or not you have a rupture of the aorta somewhere. And sometimes what happens is you actually bleed into the mediastinal space and not the pericardial space, or you bleed into a hemithorax. Then you get basically a hemothorax, and you actually have blood loss anemia and blood loss hypotension. In that case, volume, preferably with blood, is definitely the right answer. So you're probably going to activate a massive transfusion protocol rather than give them fluids, which will dilute them pretty dramatically. And so that's scenario 1. The other scenario 2 is that the person's actually in cardiogenic shock right now. And they could be in cardiogenic shock for 1 or 2 reasons. One is they have very bad aortic regurgitation. When you dissect the proximal aorta, you can actually get to a point where the valves are no longer coadapting, and then there's an enormous amount of regurg, which drops your blood pressure and drops your cardiac output. There's not much you could do for that. This is a surgical problem. The most important thing is to not slow them down, because the faster they are, the less regurg there is. Obviously, you wouldn't slow them down if their blood pressure sucked anyways, and so that shouldn't be a problem. The only part that's a problem is when the blood pressure measurements were wrong. and this happens more often than we like to admit, where the initial blood pressure is reading like 140 over 130, right? And people are thinking that's a real number, and they try and treat it, but that wasn't a real number, right? And the scenario number 3 is that they're in cardiogenic shock, their heart's not squeezing well because it's transected one of the coronaries. This is also a surgical problem. You treat the underlying shock, as the best you can, which is you could try fluids, you probably try pressors and try inotropes even, but this is a surgical problem. You're just trying to buy time.
Okay. And so the last kind of bad scenario in the ED I wanted to talk about is, let's say there's some situation where you have this patient with thoracic aortic dissection, you have to intubate them. How are you going to think about this intubation, and then like what specific things you're going to be worried about and have on hand to kind of combat those problems that could arise?
So if you have to intubate them, one of the questions you have to ask is why. And there's a couple of scenarios why this might be. One is that they're not protecting their airways, and this is usually because they're hypoperfused or they're having a stroke. In these cases, the intubation plan actually changes a little bit. And the other thing you want to think about is what their hemodynamics are and what they will likely be with intubation, and what you want to avoid. So usually when we intubate people in the ICU, we're more worried about hypotension than we are worried about hypertension. Sometimes, though, you have to be equally, if not more, worried about hypertension than hypotension. And those cases are if they have a neurological disaster, like a big stroke or bleed, or in this case, if they have a dissection. And so it is equally prudent to avoid hypertension with intubation. If you got a patient who you've diagnosed with a dissection, again, you're made a note that there's no pericardial fluid. If there's no pericardial fluid, you shouldn't drop their blood pressure too much by putting them on positive pressure ventilation. Then I would be very aggressive about blunting their sympathetic tone before I intubate them. And so that involves giving them a lot of pain meds, like 200 fentanyl, and attacking their sedative plan from multiple different angles, propofol and midazolam, for example. Or if you like to use a tamponade plus something else, or generous doses of anything is going to help you blunt the sympathetic response to avoid hypertension. And then the rest of the treatment algorithm is the same. To avoid hypotension, phenylephrine, norepinephrine, fluids, whatever you like to use to rescue, all of that is important. Before you intubate too, with these dissection patients, you're really going to want that neurological exam. This makes a huge deal, especially to the subsequent teams and the surgeon. What deficits are there? So give them a really hard pinch, like really try and suss out, are they doing anything?
Yeah. Okay. So the main difference, it seems like, with this intubating these patients is worrying about hypertension, and then the rest is kind of the same, as other intubations, and attacking that from like multimodal pain control, sedation, and then whatever you need to bring their blood pressure down.
But the ones with tamponade is crazy tricky.
Yeah.
Right. So if their blood pressure is low and you diagnose them with dissection and you see the fluid collection around the heart, that's a really hard one. Intubating these patients, you probably have to intubate them with epinephrine on hand because you want them to be fast, and you probably want to give them a lot of volume before you do this. And lastly, you probably don't want to paralyze them. If you are, you're going to paralyze them with something super short like sucks, or you're going to reverse the rocuronium as rapidly as possible with Sagamodex, because that pulses thing I was telling you about, where they have venous return only when they breathe in, they have negative pressure respiration. Well, that's all gone the second you put them on positive pressure ventilation.
Okay. All right. So that seems like a very tricky situation, obviously. All right. So I think you mentioned this already, but like what lines are you going to put in this person, especially in the ED? You mentioned an art line. Are you going to put in bilateral art lines, central lines? Like what types of things would you do in the ED in terms of like invasive monitoring and lines and stuff like that?
Yeah, I think anybody who's in shock or hypotensive or have a high risk of becoming hypotensive, art line for sure, unless doing that gets in the way of definitive therapy. So if that's going to slow you down to getting them to the OR, you're going to skip it, though you're going to skip it kind of reluctantly.
Yeah.
Where to put the art line is a very interesting question with dissection, because the flap can be anywhere and can actually give you spurious numbers based on where you put it.
Yeah.
And not infrequently, we would actually put art lines in all four extremities to get a sense and get an idea where the true pressure is. And then you're titrating your nicardipine and esmolol to the highest pressure on the art lines. Having two art lines on different sides is a luxury, something that I would personally do. But I recognize in the community, if you're trying to get them shipped out, you might have to skip that step.
Yeah.
The way I think about it is this person's best shot is to go as quickly as possible to the OR. There's things I could do to help that, but I can also equally risk getting in the way of that. As an intensivist, I have the privilege of just being able to text my surgeon and being like, how far are you? Do you want me to just line this person up? And the answer is usually actually yes. They love that. And so if they're already at this institution where we're going to do the surgery and they're kind of trying to activate the OR, I can basically do part of anesthesia's job and speed things up by putting in all the art lines. And oftentimes it's actually 4, sometimes just 2, but a lot of times it's actually 4 different art lines. And then putting in a lot of times it's actually a MAC introducer with a hands-free.
Okay.